Right, let's begin. Just in my screen, okay, here. Now, good morning, good afternoon, good evening, everyone, wherever you are joining us from today. Welcome to this session of the Healthy Mothers, Healthy Babies Coffee and Chai Chat series. And my name is Martin Mwangi. I am the program lead of the Healthy Mothers, Healthy Babies program, which is hosted by the Micronutrient Forum. And I have the pleasure of moderating our conversation today. Now, HMHP is hosted by the forum, as I mentioned, and this Coffee and Chai Chat series exists to do exactly what we are about to do for the next 1 hour, which is basically bring practitioners, researchers, and policymakers together informally over a virtual coffee or chai to translate emerging evidence, for example, the one from Ethiopia today, and see what this means for maternal and newborn health. If you'd like to learn more about the HMHP, you can visit us at our website, which is going to be put in the chat. So today's conversation is titled From Evidence to Action, Lessons from Ethiopia on Scaling Multiple Micronutrient Supplementation. And it sits right at the heart of our mission at HMHP, but also for the involved organizations today, which is UNICEF Ethiopia and the Ethiopia Public Health Institute and the Ethiopia government at large through their Ministry of Health. Ethiopia carries one of the highest burdens of low birth weight in the region in Africa, and the evidence you'll hear about today shows what it takes scientifically and programmatically to move from a promising global recommendation to a costed national scale policy that reaches hundreds of thousands of pregnant women. But before we dive in, I want to give a quick round of housekeeping. So first, please introduce yourself in the chat, your name, organization, and country. Please also, you could also give us your affiliation in the chat so that people are able to reach you directly or during and after this chat. Feel free to turn your video on if you're comfortable to do so. All participants will be muted during the presentations, but you're welcome to unmute yourself during the question and answer session. So if you want to ask a question or make a comment, just raise your hand and I'll call on you. You can also drop questions in the chat box at any time, and I'll be collecting them as we go. If you run into any technical difficulties, please send a direct message to our tech support in the chat, and they will be happy to help resolve it for you. And please note that this session is being recorded, and the recording will be posted at our HMHP website. If you go to the resources tab and click under Coffee and Chai Chats, you can be able to see the recording and also share it with your colleagues. So allow me now to introduce our two speakers today. Our first speaker is going to be Dr. Masresha Tessema. Dr. Masresha is a highly accomplished public health nutritionist and senior researcher at the Ethiopia Public Health Institute, where he directs the Nutrition, Environmental Health, and Non-Communicable Diseases Research Directorate. He is the president of the Ethiopian Food and Nutrition Society and heads the SAN Academia platform, making him one of Ethiopia's national leaders in this field. His work spans implementation science and policy support on micronutrient deficiencies and malnutrition, as well as the intersection of non-communicable diseases, climate, and nutrition. He has authored more than 90 peer-reviewed publications and holds a PhD from Wageningen University here in the Netherlands. Our second speaker today is going to be Dr. Ramadhani Noor. And Dr. Ramadhani is a nutrition manager with UNICEF Ethiopia with deep experience advancing the health and nutrition of women, children, and adolescents across a range of settings. He specializes in translating evidence into policy and practice, designing and scaling integrated nutrition and health programs, and strengthening systems in resource-constrained contexts. Before this role in Ethiopia, he served as a health and nutrition specialist with UNICEF Tanzania and as a research associate at the Harvard T.H. Chan School of Public Health. Dr. Ramadhani is especially passionate about closing the gap between research, policy, and implementation. Now, both Dr. Masresha and Dr. Ramadhani will walk us through the findings of the Lancet Global Health Study on antenatal multiple micronutrient supplementation in Ethiopia, which involved over 85,000 women. And they will show us how that evidence became a national costed roadmap for scale-up through 2030. With that, I want to hand over to Dr. Masresha, who will then proceed with the next part of the presentation. So we will first listen to both Masresha and then Dr. Ramadhani, and then we'll go to the Q&A. Over to you, Dr. Masresha.
Thanks so much, Dr. Martin. I hope you can hear me, right?
Yes, you can.
Yeah, thanks you so much. Good morning, good afternoon, good evening, everyone. Indeed, I was honored to present one of the greatest study or the largest trial in Africa that we recently completed. So I will be addressing some of the key findings from our trials, and then following me, Dr. Ramadhani will address also the other components. As my name introduced, my name is Masresha Tessema. I work at Ethiopian Public Health Institute, and this work indeed has been conducted in collaboration with London School of Hygiene and Tropical Medicine, where Professor Tanya is also a co-PI in this call. Thank you so much. Next slide. So I will briefly address the key motivation why this study is needed. Can somebody unmute? Ethiopia is.
Masresha, you're muted.
Okay, thanks. One of the key motivation for this study, Ethiopia, like many other African country, we have a multiple form of micronutrient deficiency, including zinc, folate, vitamin A, and as well as vitamin D. In addition, low birth weight is highly prevalent in many parts of Ethiopia. And related with this also, stunting is one of the major public health problem in one way or another way, also relate with micronutrient deficiency as well as with low birth weight. Next slide. So the global evidence on MMS, as most of you are aware, IFA with only two nutrients, while MMS has 15 nutrients, which are very essential. We do understand, recently WHO also recommended MMS to be implemented under rigorous context. And in addition to this, regarding to MMS, there have been several evidence, particularly the several efficacious trial already conducted. With those trials, Cochrane review also come with some evidence, as you can see. MMS compared with IFA can reduce 30% of reduction in low birth weight, as well as reduction of 9% on small for gestational age. So in order to implement this global evidence, Ethiopia requires to have a local evidence, meaning the rigorous evidence before we pilot or translate IFA to MMS. Next slide. So regarding the evaluation of this evaluation had two-arm cluster randomized controlled trial conducted in 5 regions, which cover about 60% of the total population, which we did in about 100 health facility, both hospital and health center. And in total, we were able to recruit 85,619 child mother. And briefly about the methods, for the primary outcome, we were able to collect continuous data, in particular the birth weight data in 24 months between 2023 and 2024. And there are also other indicators that we collected, including the ANC use, the use of supplement, both IFA and MMS. And in addition, also adherence were also being collected. Next slide. So we have, sorry, can you go back? And briefly, we have several objectives. And the first primary objective we have, the look at to change on the effectiveness of change in mean birth weight of those mother or children born in MMS compared with IFA. And there are several secondary objectives, including the cost effectiveness, adherence, and the coverage, and as well as we have qualitative study to look at change or the mechanism of change. And as I said, the primary outcome were collected in the continuous data in 24 months as indicated. And in addition, we have also collected other information, in particularly the implementation research during the baseline, midline, and endline. And we were trying to capture, the experience of women who receive both MMS and IFA, as well as the health worker who deliver the program were addressed. And we have also a cost data that were collected in the project study time. Next slide. I will address on this slide how the evaluation was implemented, and I will address 4 major components. The first one is there was an ownership from the national government to the lower administrative level. Prior to the initiation of the trial design and the study, there was a consensus and agreement at the national level. Later, we were able to also get engaged and get consensus at lower administrative level. And the second one is there was a very effective coordination mechanism between the implementers, the evaluator, as well as with the donor. We have regular feedbacks and discussion with all of those key stakeholders. And the other one is the capacity building. We were able to use the routine data where we were able to build the capacity of the midwives or the health worker in the health system and to use the data and in particularly to measure the primary outcome. And the last one, we were able to utilize also the routine data, which had been the existing health system data. We were able to improve the data through the capacity building on the third point, which I mentioned. Next slide. This is the result. As you can see, this is adherence. Adherence to supplement at least for 90 days, as you can see, increase in both arms. However, as you can see that the greater or the higher impact were seen on the MMS arm, as you can see, which the effect is consistently high, which is 85% of the mother adhere at least 19 days on MMS compared with IFA, which is only 53%. Next slide. So this is the primary outcome. As you can see that, the effect on the mean birth weight when we compare with IFA, and children born in MMS arm has 38 gram mean birth weight higher than compared with IFA. And as you can see, the horizontal dotted line, which is the rollout phase, and there was a very small change during the rollout phase, but after rollout phase, you can see there is a consistent effect on or change on the mean birth weight, as you can see, 38 gram. When we translate this effect, despite it has not been powered, but you can see this is about 27% reduction in low birth weight compared with IFA. And next slide. So in addition, we were able to see also the effect, and there was a greater or stronger effect, especially for those women who took at least 90 days. As you can see, the overall effect was 38 gram, but when we look at those women who receive at least 90 days, the effect was greater, about 60 gram or 58 gram, which is indicate that there is a dose-response relationship. Next slide. So one of the learning from the evaluation is, as I said, there was a clear, dose-response relationship, for with relativism, particularly with adherence, meaning the higher adherence would have the higher impact or the improvement on the birth weight. And during the trial, we were able to measure also the effective coverage. The effective coverage in both arms has been increased, but there was a greater, improvement on effective coverage on MMS arm, as you can see, from 7% to 18%, and meaning that if the effective coverage is higher, you might see even a bigger impact on MMS. And we were also able to measure the cost effectiveness. MMS is cost effective in terms of cost, which we are not able to present, but we are able to show that there is high return investment on cell learning. Next slide. So as we look forward, as MMS has been scaled up in Ethiopia, there are issues need to be addressed. The first one we need to address, in particularly the coverage, when the effective coverage need to be addressed. And related with this also, there is a mechanism which we can also leverage or use routine data, which is very important, to use this routine data as far as the quality is improved. And the other one is the early initiation of NEC is an important component need to be addressed. This is the main bottleneck in many settings that has to be addressed. And of course, we need to address some cultural norm. It has to be addressed, which would be some of it are related with family. And of course, where we are looking forward, to scale up, we need to also look at the health benefit, the other health benefits, and impact of MMS has to be addressed. Next slide. So I will not address the roadmap, and my colleagues, Dr. Ramadhani, will address on the next slide. But as you can see, that Ethiopia has a cost roadmap, and we need to have also a sustainability plan, in particularly where IFA to MMS transition. We need to have a local production. Next slide. So I have, in conclusion, two key message as the research key outcome. MMS can improve the birth weight in Ethiopia relative to IFA. And while the scaling up is being continued, we need to have adequate program support in order the program to be implemented effectively. And next slide. So I would like to thank the study participants, our research team members, and also our research assistant who collected the data, and most importantly, the women who have been able to consent and provided all this information. And this is my contact if you have any question. And you can, of course, access also the trial result which are published in the Lancet. You can see from this. And with this, thanks so much, and over to you, Dr. Ramadhani.
Thank you so much, Dr. Masresha. That's a powerful body of evidence, and it really underscores why Ethiopia's demonstration trial has become a reference point for other countries well beyond Ethiopia. And we are hoping to learn more as you continue to analyze the data. We now turn from the evidence itself to how it has moved into policy and national scale up. And with this, I want to hand over to Dr. Ramadhani. Over to you, Dr. Ramadhani.
Thank you so much, Martin, and I hope you can hear me. Thanks, Dr. Masresha,
Yes.
also for presenting the evidence that came up. I'm happy to share with you now the whole process in terms of transitioning from evidence to the scale-up program. Next slide. So Dr. Masresha has presented before you that Ethiopia government response really came, driven by the evidence and the data justification in terms of the burden that we have seen for maternal undernutrition. 2/3 maternal micronutrient deficiencies, anemias are quite high. It contributes to poor birth outcomes, especially low birth weight. Almost 400,000 babies or children are born with low birth weight annually in Ethiopia. Neurotube defects quite high, 63 to 83 per 10,000 births, which almost 30,000. So there was already a justification for Ethiopia government to really align with the WHO recommendations to be able to demonstrate and implement or roll out MMS at scale. But then it required rigorous research, as it has been recommended. Happy to tell you that Ethiopia government did that successfully. In December last year, Ethiopia had transition policy-wise to the rollout and scale-up of MMS. Next slide. So to do so, we had to design a demonstration program so that we could generate local evidence that was required by the government of Ethiopia, particularly the Minister of Health, And the objectives were more not just the switch of the peel MMS or from IFA to MMS, but we really wanted to learn on how we can use the introduction of MMS to improve the delivery of maternal nutrition services, particularly through the ANC system. So that was more of the overall goal. Specifically, we were aware of the challenges that the program had been facing from IFA coverage. So we wanted to ensure that we generate demand and we sustain high demand, but also we wanted to demonstrate how we can improve through MMS as an entry point, quality of services through the ANC, as well as increasing coverage, uptake, and compliance for ANC. Secondarily, also, we wanted to demonstrate sort of market-based approaches, so social marketing, and I'll tell you more about it, and at least to start to explore now the journey towards local production of MMS in Ethiopia. So demonstration itself was into two main parts. So there was a rural model, which goes through the public facilities through ANC, and then we have the urban model, which had the public component as compared to the rural, but in addition, we had the social marketing that was done in collaboration with MSI. Next slide. One thing that is so special for the demonstration program that was implemented in Ethiopia is there was an intentional focus on ensuring that we generate demand for ANC and we sustain that demand. So the focus on social behavior change, it's one of the strongest pillar or a central pillar. And with this, I think we had worked with the University of Addis Ababa, where they were supported to establish what we call the BED Lab. This is the Behavioral Insight Research and Design Lab. And they were really instrumental in terms of undertaking the behavioral insight research, really mapping up the opportunities and the barriers that are faced by both women, the pregnant mothers, but also the healthcare workers, and really go through the whole journey before the woman leaves home, by the time they get to the facility, and when they're receiving the care at the facility and beyond. And from those assessments, they were able to design prototypes. These are locally informed, and they were able to be tested so that we could have very specific interventions that are effective in generating demand in the context of Ethiopia. And these were compiled into a social behavior strategy that we validated through the demonstration program and was adopted with the further scale-up effort. Next slide. As a result, I think in addition to the social behavior change, also we had worked in collaboration with the Maria Stopes International to also demonstrate the social marketing component. About 10 to 15% of the women, particularly pregnant women who are in urban settings, they tend to receive care or ANC care in private provider or through private provider settings. So this is settings outside the public ANC. So we had worked with Maria Stopes, who are really supporting a franchise of this public provider system, and they had already been implemented a portfolio of social marketing products. With it, they were implementing Pregnavit, and they were intending now to switch and upgrade from Pregnavit to a Unimap formulation. So that was an opportunity for us to work with them to be able to shift to a Unimap formulation. So they were able to identify a producer who is Renata, Bangladesh. They were able to brand that particular Unimap formulation that will be specific for social marketing, different from the one that will be given through public facilities, get it EFDA registered here in Ethiopia, build the capacity of those who implemented the work, and also started the campaigns. Where we are now, I think Maria Stopes is about to launch this program in a month or so and really be able to scale up this social marketing program, part of the program. Next slide. So we had so far reached around 633 women. So we are tracking the numbers that are being enrolled. Around 423,000 women were reached through the demonstration phase. And now we have this seamless transition to roll out to scale up in line with the roadmap that I will tell you a bit more later, that has, collectively give us around 633K women. The program is implemented again as in sort of 3 or 4 components. So there's an integrated delivery. We've integrated MMS into the existing ANC system for the districts that are implementing MMS, but also we focus on demand generation, as I've shared with you, supporting the supply chain system, but also support the real-time data using existing DHIS data system. Next slide. So Dr. Masresha has shared with you the sort of the evaluation findings that came out from the implementation of this demonstration program. But in addition, there were additional learnings that we had learned from the existing data and some small studies on adherence. One study that we had done is a study that we implemented in collaboration with the Johns Hopkins and Addis Ababa University, just so to understand, one, what is the appropriate way of monitoring adherence and measuring adherence through the routine care. So they tested the different recall sort of approaches against the bottle weighing as a standard, and a 30-day recall was picked up to be reasonably good and reliable for programmatic monitoring. And I think with it, they're also able to demonstrate preliminary data showing high adherence with about 54.4 women having excellent adherence. This is those who had adherence of 90% of what they were supposed to consume upwards, and others having good adherence, those who had 75 to 89% of the capsules consumed against what they were supposed to consume. But in addition, also, we're able to look at the DHIS data, and we're able to see that at the those MMS implementing districts had improved early ANC. I think it's a jump of about 13 percentage points compared to where they are. And where it is now, it's almost at the demonstration, we've gone from 35 to almost 48. Vis-a-vis the national sort of early ANC average of 31%. Most importantly, also, we're able to see that, there are equity gaps. So if you compare urban women vis-a-vis rural women are less, having less adherence. The same with those who are educated vis-a-vis less educated. But even more striking is the comparison of those who are adult women and young mothers. Young mothers seem to have less adherence. And I think this points out to importance of paying attention to adherence, but even more so paying attention to these equity gaps going forward. Next slide. When we started, we had said that we wanted to use MMS as an entry point, and we were able to demonstrate that really MMS introduction to Ethiopia became an entry point for stronger ANC care. We could see when you compare the MMS districts vis-a-vis the IFA, and this is just the program data, MMS districts were performing better in terms of ANC attendance, the same as hemoglobin testing, and I think that is driven by the attendance itself. The quality of nutrition counseling also seemed to be higher, and they received either of the MMS or IFA that seemed to be higher also on the MMS implementing districts, as well as those who came back for the post-care utilization. MMS districts perform better. So we have data that showcase, and these come from the end line evaluation that was performed by our colleagues EPHI with support by London School, that actually really we were able to showcase introducing MMS could also improve delivery of antenatal care services. Next slide. So from these data, we had parallel established an independent technical advisory group led by the experts from Ethiopia, who had looked at the global evidence as well as the local evidence and compiled it to inform the policy brief by the Minister of Health. And that policy brief also, and this evidence informed the interim guideline for transitioning from IFA to MMS. So this is how useful the evidence that came up and the lessons that came up from the demonstration program really informed that policy translation or transition at the higher level by the Minister of Health, and further guidance on how we can proceed to scale up MMS in Ethiopia. Next slide. In addition, this demonstration program and the evidence informed also the roadmap. This is the costed roadmap. It actually was done in collaboration with the R4D. This costed roadmap actually identify those priority and necessary activities that needed to be supported or implemented to facilitate the transition from demonstration to scale, but also costed those activities. So we were able to tell how much is needed to be able to implement MMS to a national scale up by 2030. I think one experience that came up from this roadmap development is the fact that through consultation with different partners who were involved, we were able to go through series of discussion to really prioritize and end up with the necessary activities that needs to be funded to accelerate the transition. The danger is obviously always, to condition much of the health system strengthening activities, which apparently that is already happening in parallel, but we did not want to condition those aspects as a necessity for the MMS introduction to scale, given that the evidence and the demonstration had shown that implementing MMS, even with through the existing system, was able to provide or sort of translated the impact that we have seen with the global evidence. Next slide. So with the costed roadmap, I think you could see different categories of the cost, but I think one important point is that the total cost of $63.5 million was estimated to support MMS transition to national scale-up by 2030 in Ethiopia. 70% of that cost is the cost of the commodity. So I think that's the most important message that came up with it. The second part that came up with the costed roadmap is that it allowed us to have a scale-up plan, which implies or indicates Ethiopia plan to enroll 200 new woredas or districts every year to reach the target of a national scale-up by 2030. Next slide. So currently now we transition to also generate an investment case, and through that investment case, resource mobilization, working with partners, with further support from CIF, and working with other partners to optimize the ANC platform. This is the work that we have embarked on, supporting the government of Ethiopia from 2026 to 2030 to be able to roll out the MMS at scale as planned by or indicated by the roadmap. Next slide. So finally, in summary, I would say that through this work, what we were able to finally come out to document is a framework with which has been instrumental to ensure that we're able to accelerate the transition from evidence to policy and scale up in Ethiopia within a period of 5 years. Since we started with the evidence, building upon the global evidence and the national priorities 2022, it's been, I think now, 4 or 5 years where we're able to really push the program to scale. Normally, this sort of transition will take many more years. This framework, I think it's been helpful in terms of stages. So the first pillar is really around building the global evidence and national priorities. And then we moved to a second pillar, which was more of the demonstration program. And under each of these pillars, there are priorities, activities that we have undertaken. Same as moving to transition to policy, and finally financing and scale up, which is currently the phase where we are now, focusing on how we can sort of nurture the ecosystem, so bring in more players to support the government to scale. How can we optimize the market? How can we unlock the financing and reinforce the platform, especially the ANC platform, and integrate MMS itself into the ANC care as a national program. So this is the first where we are now. Going forward, 2030, we'll be looking at sustainability, where issues of local production priority, and this is where the government of Ethiopia has started to pay attention to. So I think this is just to give you that framework that we have used to bring in the agility that is required to transition from evidence to policy to program at scale. Next slide. So thank you so much. I think this is my last slide, and really sincere thanks to many partners who have contributed to this work. Foundational support that came from CIF, additional support from Bill and Melinda Gates or Gates Foundation, but working very close with collaboration, EPHI, London School, John Hopkins, and other colleagues. Thank you so much.
Thank you very much, Dr. Ramadhani, but also Dr. Masresha for taking us through the Ethiopia journey. Now, what a rich journey! It's coming all the way from the cluster randomized trial all the way to the fully costed government or national roadmap. It's basically what we like to see in nutrition, where evidence-based interventions get onboarded. Now, we now have time for questions. And as a reminder, please raise your hand if you'd like to ask a question. You are free to unmute yourself, put on your video, and ask your question directly to any of the speakers. Or, and I will start with the questions already that are in the chat. I see quite a bit of questions there, and some have already started being answered by some of my colleagues. We'll do our best to get through as many questions as possible. And if we are not able to answer your question today, we will prepare answers and send it to you post the meeting. So I want to start with a question by Mohammed Tukur, who asks, he does not direct his question to a specific speaker, but he says, good presentation. My question is, what are measures considered to improve high adherence to MMS administration at low communities where the level of socioeconomic status is very low? And he gives the example of Kaduna State in Nigeria, where most women in his community show low levels of adherence, especially those who are going to attend the primary healthcare centers. Do you want to reflect on this? Perhaps this is a question for Ramadhani.
So I think to answer the question, and it's a very good question, because this is an area where we have also spent a lot of time to figure out how can we generate, and it's not the question of adherence itself. What we have learned, sometimes it's very important we pay attention to adherence, but also adherence it's a product, and it's a very sort of a slice out of the whole question of effectiveness coverage. So I think I would push that question even further to say, how do we improve effectiveness coverage? Effective coverage meaning that starting from the very beginning, when the women are pregnant, can they come in early to the ANC? Are they coming frequently? And when they come, do they receive the quality of service that they receive? Do they receive the counseling that they need? Do they receive the product itself from the beginning, given the stock-out challenges and so forth? And when they receive the product, are they able to comply? So you would see that even before we get to pay attention to the adherence itself by women, we need to look at the sort of this whole cascade of issues that will eventually affect. Now, coming to the question itself, I think I would say we need to pay attention to context. Different contexts. Some contexts are polycrisis. Some contexts are challenges, whether maybe they're agrarian or they're pastoralist. There are contexts where the access to health services is higher, or in contexts where, communities are moving around, where you have to use the outreach. So I think paying attention to context is important. It's important to co-create those interventions and test them to see which one works well. In the context of Ethiopia, for example, we were able to test an intervention, and we found that actually the pregnant mother conferences, it's the convening of pregnant women that happens monthly within the vicinity of the healthcare. and they will be receiving group counseling and messaging with the support of the health extension workers, but also other cadres who are important in the community. These are the mother-to-mother peer support, was very instrumental in terms of promoting the
I
guidance.
will ask you to be brief so that we are having quite a lot of questions so that we
absolutely. So context and designing those solutions, I think, will be very important. Paying attention that equity gap, particularly young mothers, also will be key. I'll stop up here.
Thank you very much. That has been exhaustively covered. Dr. Masresha, I think you mentioned about adherence, that women attended their first NC visit in the first trimester, and you are checking at the 90 plus, how many took 90 plus tablets. There is a question for you about women attending their first ANC visit in the first trimester. How did you manage? What are the challenges you experienced recruiting women here at this stage, and encourage them to start earlier in ANC so that you could follow them up longer? And are there lessons for other countries?
Thanks so much, Martin. Yeah, of course, the trials that we implemented are embedded under the bigger national or the pilot programs where we selected facility or delivery services. So in this case, almost all the women have been recruited under the routine ANC system, but for the sake of our trials, we were able to get a consent where the women have been consented to be part of the study. Because MMS, the way that MMS has been implemented is, it was like on the Warada or district where MMS implemented, and the government took out all IFAs from that district or facility. So it is blanket district implementation. So that's how we implemented. Of course, as Ramadhani said, the effective coverage that we were able to was able to present has been to somehow, as in both arms, has been very low, about 7%. But at the end of the trial, there have been some improvements, but the bigger improvement was on the MMS arm. So that required a lot of work. I mean, there are several cascaded components of effective coverage, including the first ANC visit and the service they receive, and also just the stock or the supply availability. So I think one of the challenge in terms of the implementation of the trial is, and this is a new product where, to, introduce, where this has been a research component, not, the programs that would be. And the second component, measurement of the primary outcome, which in many of the facility, we need to improve the quality of the routine data that, took a lot of capacity building works in the facilities, in all of the facilities, that also to somehow challenging work. And then I think these are the few challenge that we were able to face during the implementation.
Perhaps related to that, John Atwater, and I don't know that John wants to unmute himself and ask his question directly to you. I'll give him 5 seconds to decide, and otherwise I ask for him. It's related to the same distribution of MMS, and he's asking about why was 90 days rather than 180 days used for the use period? And related to that, the packaging configuration for the Unimap MMS product. Can you quickly address that? 1 minute or less?
Yeah, I'll be happy. I mean, in terms of the analysis that I was able to present, we were not able to look at, exclude the 80 plus, but the effect or the biological effect or the birth weight effect that we were able to see is at least those women who receive 90 or at least 90 has a greater effect. So this means that, less than, or those women who are receiving less than 90 do not have effect or, a positive effect compared with the other groups. So that's what we were able to see. We were not able to recommend like 180, but based on this evidence, at least if the woman received 90, So there is a likely that the woman, the childbirth weight would be improved. That is what we want to pass the message. Of course, on IFA, there have been some evidence where, on the IFA, the woman has to receive 90 plus, or in some other setting also 118. But in our case, I think if the woman at least receive 19 would be to somehow, sufficient to see some biological effect. And this could also lead us, some packaging and other issues when we go to the program implementation. Yeah.
And
maybe
suppose
just to add, I think also it's also possible that the 90 days plus a proxy of the women who really adhered for much higher days, closer to 180. So that needs to be examined going forward. Thank you. Yeah.
Just from my understanding, how many tablets were in each bottle?
100.
100.
And they were given 2 bottles. Yeah.
2 bottles.
So a woman could potentially could have had 200 tablets.
Yeah.
Okay, that clarifies. And Happiness Biengo is asking, currently as we speak, are the districts receiving MMS? Is the program ongoing? Just a quick comment on the current status.
Yes, it has been. We have now implemented the phased approach. Of course, now at the moment, over 100 district has been translated from IFA to MMS. And by end of 2030, the ministry has planned to have all the district as MMS, meaning that there are still several districts in Ethiopia as IFAs implemented. Yeah. So we are following the phased approach.
That's well understood. Still receiving questions here. One other question is coming from, I believe it's Adaji. He's asking, what is the acceptance of the Ethiopian government on the cost of adopting MMS into the, I believe it means the government program now, outside of the research agenda?
Yeah.
After that, we are going to go to Saba Abraham. I will come to you. Your hand is raised, so you can prepare to unmute and ask your question. But first, answer this one.
Yeah, just quickly to respond this. Yes, in terms of the absolute cost, MMS is higher than IFA, but the cost effectiveness, the way it calculated with the health outcome, and there are models which include also the low birth weight, some with mortality, morbidity, and other benefits from the literature. Based on that, MMS as cost effective, and that paper is also coming in. The government accepted that result, and moving forward to the translation or transitioning to MMS. That's the short answer. Yeah.
Very good. Saba, do you want to unmute yourself, perhaps also put on your video and ask your question? Keep it very brief and to the point.
Thank you for the informative presentation, and my questions goes to maybe to both of them. So first of all,
could you mention from where you are joining? Asking from?
I am from Ethiopia. Currently, I'm in Belgium for my PhD study.
Okay, go ahead.
So I appreciate all the efforts you have really made. That is wonderful. But may I know if there any assessment targeting the side effect of these products? Because as you know, so many side effects were raised by pregnant women in IFA's provision. So maybe Ramadhani, you mentioned that you address the knowledge gaps through peer education. That's a good point. But I would like to know whether there is a difference in side effects, for example, the gastric limitations that restricts pregnant women from taking IFAs previously. So if there is any improvements in this MMS, and how did you assess this? If you assess that, thank you so much.
So, question on side effect assessments. As you prepare to answer that, I believe Ramadhani, let's take a second question from Muhammad to Noor, so that then we can take both of them together. So, Muhammad, please unmute yourself, and if you want to put on your video, that's also okay, and ask your question.
Okay, thank you. My name is Dr. Muhammad Tukur from Kaduna State, Nigeria. My question is there any physiological effects of this MMS on pregnant women in early pregnancy? because sometimes we have such a complaint when we go to fields. They say their stomach pain, all this, they are very fatigued, and all these early sign effects. So I don't know if it is from the MMS or it is other substances. Thank you, sir.
Okay, and in addition to that, and then I'll let the speakers answer, and then we'll take another round of questions. There is another question about the supply chain. That is from Meng. Is asking, does MMS go to MOH first and then it's distributed to health facilities, or how does it work? So if you can combine those three questions, and then we'll take another round of questions. Who wants to go first?
Yeah, so happy to come in first with the side effects.
Okay.
So we looked at the experiences of women on side effects, and this is part of the data that's been collected with the evaluation team. Dr. Masresha can say more about it, and reviewed by the independent tag as well. And what we have learned is that actually those women who are receiving MMS had less sort of incidents reported, particularly the gastric upset or the change of the stools compared to the IFA. So that is just to give a quick answer. On the supply chain, so we have UNICEF supports the Ministry of Health Ethiopia to procure the supplies and the shipment into Ethiopia. Once it gets to Ethiopia, we integrate it to the existing system, which send the supplies all the way to the zonal, to the regions and the woredas. In instances where the last mile access is challenged, UNICEF will support that. But we have tried to use as much as possible the existing supply chain in Ethiopia. And going forward, we are looking into strengthen that supply chain system to support the scale up and the distribution of MMS to all the districts. Thank you.
What do you, Masresha?
I think Ramadhani answered both questions. I think the first and the second are both related with a side effect, where there is a paper that will be coming soon from the trial as secondary outcome. So there is no big difference. Even the side effect is a little bit higher on IFA groups than MMS, as mentioned. And the supply chain related, we would be following, there is Ethiopian Pharmaceutical Supply Agency, which distribute all the supplement or IFA. So we'll follow the same pattern for MMS when it is or it will be fully scaled up. That's what in short answer. Thanks.
Right. Couple of other questions, and I don't have any hand up. So if you want to ask your question directly, you can raise up your hand. Otherwise, I'll take them from the chat. Shimeli's Tizazo Cherry is asking three questions. I will skip those that I think have already been answered, but the first one is about financing. Is there a strategy in place to secure sustainable financing or funding for the scale up of MMS, for long-term program sustainability? And the second question, I believe that one can be taken by any of you, depending on who has been handling that portfolio locally. I believe Ramadhani mentioned something to do with CIF and related programs, so decide. The second one is, are there plans for community mobilization and nutrition education to promote acceptance and ensure broad community engagement for greater impact? And the last one is there an M&E plan in place to systematically track program coverage and measure the overall impact of MS implementation? So that's our three questions. I see Margaret is having her hand up. Margaret, do you want to ask a question directly?
Yes. So thank you for the presentations. I'm Dr. Tohwenu, a Ghanaian based in Abidjan. I wanted to find out, usually, just as happens with breastfeeding, sometimes there are people in the community, in the family who influence, the subjects, either positively or negatively to continue. Did you have such problems, with your study participants having to be influenced by such stakeholders not to adhere to the taking of the supplements?
Good question. And then there is a last question, and I believe probably this will be almost the second to last question that we take. This is from Regasa Terefe. He's asking, is the allocation of MMS tablets fixed at 200 tablets per woman for the entire pregnancy, or can the number of tablets be increased depending on the woman's health condition or clinical assessment, or I believe the stage at which she joined, when you got her into especially if she initiates, enters the program early enough. Shall we take these three, and then perhaps we might have a chance for one last question before we close?
Sounds good. I can quickly go with the financing and maybe the tablets and adherence. So on the financing, we are supporting the government of Ethiopia to develop a financing strategy. And I think part of this process started with the costed roadmap, which had given an indication of how much is needed to support the transition. And then based on that, we were able to develop an investment case for MMS in Ethiopia. And we've been using that investment case to mobilize support and resources from donors like CIF and others. But also we are working with the government to develop the strategy itself, or the financial plan, which has three parts. One, identifying domestic financing that's available, which could potentially be used for match funding. Two, identifying the gaps that we have for each year, 2026, 27, going forward, and then opportunities to cover those gaps, so scenarios. And opportunities include some of the global instruments like Child Nutrition Fund and so forth. So that's very briefly on their financing. With regard to the bottles, the 200 bottles is really based on, we had received bottles that have 100 MMS tablets in each. We contemplated the discussion to sort of open the bottles and count based on when the women came in. But the experience and the guidance is, once you open the bottles and you start to count the tablets, there's one chance of contamination, but also you expose those tablets to not the original condition of storage. So we prefer to provide all the 2 bottles, which is 200. And the guidance is that even post-delivery, when the women still have some capsules or MMS tablets remain, we recommended that they continue to take them through the breastfeeding period. So that has been the practice so far. On adherence, I think very quick, we do understand that cultural norms are an important barrier in Ethiopia. And in this case, we use the platforms, the monthly pregnant mother conferences, to address and sort of strengthen sort of women understanding, but also women to women support, so that they can adhere. But also, upon the interventions that we have designed locally, some of them had involved many involvement, and that has been quite instrumental at the household level. So a lot of it is context-based, and part of the solutions implemented that address those bottlenecks at households as well. Thank you.
Okay. Masresha, do you want to also react in 1 minute? But before you react, I would like to ask Ramadhani to give his closing remarks because of time. And I know that we still have one hand up. So after Masresha, I will ask Pat to keep her question in 20 seconds, and Masresha will react to that and also give his closing statements. Ramadhani, your closing one.
Thanks. So I think even though we have presented, this is a very beautiful, a classic example of how to transition from evidence to policy to program scale up. I think for other countries that are at this stage now, they can take an advantage of the existing body of evidence from Africa, Ethiopia, contributing to the global, to really leapfrog and accelerate. There might not be need to really focusing on generating evidence on the effectiveness, but rather focusing on the how part and how can we accelerate addressing issues of the financing, addressing issues of sustainability going forward. So I think that's my key message. Thank you so much.
Very well said.
Yeah.
Pat, before you come in, Masresha, Pat, do you want to ask your question in 20 seconds?
Yeah, so I was just wondering around the financing. The financing for development conference said about scalable solutions, debt swap. So it seems like this might be an initiative that could be appropriate here. It's the first question, if that has been considered. The second question is, was there any, apart from birth weight, was there any positive outcomes for the mother's outcome? I'm thinking about severe bleeding, etc., maybe even maternal mortality. Has there been any work done on this? Has that been observed? Thank you.
In the interest of time, I will request that we pack some of these answers for you via email. And for now, Masresha gives his closing statements, and then we will get the answers from him and channel them to you so that we keep with the 1 hour. Go ahead, Masresha.
Thanks, Martin. Thanks, everyone, for your very nice question. Just to reflect one thing on financing, in addition to what Ramadhani said, I think Ethiopia is now looking as a priority. The local production is a key priority. Even the individual woman can share the cost as far as the product is produced locally. I think that's a key message on finance. And the second question, which Ramadhani was not able to address, is in terms of the plan to mobilize the community behavioral change. We have on the roadmap, there is a behavioral change strategy and demand creation. So we'll be using the same platform where the health extension programs, which is one of the best in the world, that will be using that programs where the health worker would aware and create the demand on the pregnant woman. That's the key message that I would like to. For the sake of time, I will stop here and back to Martin. Thanks everyone for your interest and all the questions. Happy also to respond later if by anyone sent by email. Yeah, thanks. Over to you.
Now, we're just about at time now, and so it's a pity that we have to close. I see Ahmed, for instance, is still waiting to ask a question, but we'll have to stop here for now. Dr. Masresha, Dr. Ramadhani, thank you so much both, truly, for giving us this masterclass of what it takes to move from a well-designed trial to a government-owned costed national program, and seeing how partners such as UNICEF and many others who are mentioned today play a role in this onboarding of evidence-based nutrition interventions. To everyone who joined us, thank you so much for your questions, your engagement. We will provide answers and send them to you via email. And stay tuned for our next coffee and chai chat, and we will share details soon through the usual channels. Otherwise, for now, thank you again for joining us, and do have a wonderful rest of your day.
Thank you so much.
Thank you.
Thank
Thank
you.
you so much.
Bye.
Thank you.
Thank you so much.
Bye.
Thank you. Bye-bye.
Thank you. Thank you.
Bye bye. Merci beaucoup.
Bye-bye.